Hello, dear learners. A warm welcome to my channel, Microbiology Tutorials and Shilkumar. Today, I am going to discuss about a very important topic regarding immunology, and that is about immunodeficiency diseases. So, first of all, we have to discuss that what is the immunodeficiency diseases. So, we know that when any disease, infections, or disorders occurs in the body, so mostly we see that either pathogens or any foreign microorganisms, infectious, or through any of the infectious agents which enter into the body, and the immune response against those foreign pathogens which are harmful to our body. Now, in a normal human being, usually what happens that there is an interaction between the antigens and immunocompetent cells, and the body's in defense mechanism or immune system tries to eliminate those pathogens. And if they are able to eliminate the pathogens, the body remains healthy. And if any type of infection or which have been acquired through different microorganisms or any other agents overpowers the immune system, the disease occurs. Now, the second condition which persists is that what happens when the immune system of the body itself is not competent enough to produce immunocompetent cells. So, as such cases or under such circumstances, the body's host cells become susceptible to different type of infections, and it may be on a repeated mode, and it does not restricted to any particular pathogen, but it may be either bacterial, viral, parasitic, or fungal infections. Now, if you would be knowing that the defense mechanism of our body is regulated by white blood cells, and white blood cells produce different type of cells like neutrophils, monocytes, lymphocytes, eosinophils, and basophils. And directly or indirectly, they are involved in the defense mechanism of the body. So, lymphocytes are mostly responsible for synthesis of B cells, which further produce plasma and then antibodies. And T lymphocytes are producing T helper cells, which helps in suppressor T cells activity, which enhances, as well as it induces B cells to produce antibodies. Next important thing, in addition to WBC cells, there are some other cells in the body which also helps or assist in these cells in eliminating the pathogens. And in those, one of the important is the complement system. So complement system contains of a group of proteins which augments the WBC cells, especially the neutrophils and monocytes in the tissues when they migrate into the tissues as tissue macrophages in phagocytosing the pathogens. Next important is the phagocytic cells, non-specific phagocytic cells like dendritic cells or mast cells, which also helps in the elimination of the pathogens. So here, when we discuss about the immunodeficiency diseases, so if we divide it, so basically we divide it into two types. One is the primary immunodeficiency and other is the secondary immunodeficiency. Primary immunodeficiencies are such type of immunodeficiencies which results from the abnormalities in the development of immune mechanisms. So if completely the procedure of formation of immune cells are obstructed and the desired immunocompetent cells are not able to synthesize or there is a deficiency, that is called as the primary immunodeficiency. Whereas secondary immunodeficiency are such type of immunodeficiencies which results due to the consequences of some other factors. For example, like administration of some drugs which suppresses the immune system, or under the malignancy conditions, then malnutritions. So these are some of the conditions in which there is an interference in the proper functioning of the immune system, and finally it results into the secondary immunodeficiency diseases. So we can say overall, if we describe immunodeficiency, so it is an impairment of the functioning of the immune system, and due to the impairment the host becomes susceptible to different type of infections. Now these infections can be of varying degree from mild, moderate or severe type. Next here, these deficiencies can be either congenital or acquired. Well, if I say it is congenital, so it is that is transferred from the parents to the offspring due to some mutations in their genes and which are expressed in the offsprings or to the progeny. Whereas acquired is such type of immunodeficiency which has been acquired through the lifetime. When they pass through their life cycle or when they are in their life period, so when they encounter different type of factors, as already I discussed, mostly secondary immunodeficiency are a type of acquired immunodeficiency. So in that cases, suppose a person is administered some drugs which suppresses its immune system, or due to malnutrition, the immune cells are not capable to work properly, and other conditions which we will discuss in this chapter. So these all leads to the type of secondary immunodeficiency. So here we will discuss about it in detail. So here you can see here that if we classify, so immunodeficient diseases are the conditions where the defense mechanism of the host are impaired, leading to related microbial infections and sometimes enhanced susceptibility to malignancies. Classification: congenital diseases or primary immunodeficiency results from abnormality in the development of immune mechanism. Acquired disease secondary, it is due to consequences of malignancies, medication, medical diseases, malnutrition, other factors that affect the normal functions of immune system. In addition to there may be also some other factors which hinder the functioning of the immune system. Now here there is some list of some of the important immunodeficiency disorders. As you can see here, there is a first is the related to the B cell deficiency, and here we can say that is X-linked gamma globulinemia, which is also called as the Bruton's disease. And here we can see that specific deficiencies is that there is absence of B cells, and obviously we know that B cells are responsible for synthesis of antibodies or formation of antibodies. So here there is a very low immunoglobulin levels, and it is usually due to the mutation in the gene which is causing which is responsible for synthesis of tyrosine kinase, and as such uh, because there is a mutant gene here for tyrosine kinase, so it becomes a different type of pyogenic infection. So it can encounter recurrent pyogenic infections throughout its lifetime. Next is the selective IgA immunodeficiency, where there is very low IgA levels, especially IgA. All other immunoglobulins are normal, but especially the immunoglobulin A level becomes very low, and it is due to failure of heavy chain gene switching. Now, if you would have been idea of some about the development of immune system, you'd be knowing that there is a class switching of the immunoglobulin. So basically, they are mostly earlier synthesized as IgM or IgD antibody, and after that there is a class switching, means that they then differentiate into different type of antibodies, IgG, IgA, and IgE. So here what happens that due to there is some defect in the gene, they are not able to switch themselves into the type of IgA immunoglobulin, and as such there is a deficiency. And here the most common in clinical features of sinus and lung infection. So respiratory infections in patients who suffers this selective IgA immunodeficiency are more prone to sinus and lung infections. Now coming to the, if I discuss more about the B linked disorders, some others are like transient hypogammaglobulinemia of infancy, then common variable immunodeficiency. So here you can see here X-linked hypogammaglobulinemia, that is Bruton's A gamma globulinemia. It is the first immunodeficiency disease, and it was the first immunodeficiency disease to be recognized and was first described by Bruton in the year 1952. It is seen only in male infants, and it is due to the defect of failure of pre-B cells to differentiate into mature B cells. This failure is caused by mutation in the gene encoding tyrosine kinase. Patients suffer from recurrent infections with pyogenic bacteria. Pyogenic bacteria means that is the pus producing bacteria, and all classes of immunoglobulins are grossly depleted. Cell mediated immunity is relatively normal. Here, routine injections of normal immunoglobulins is the mode of treatment. Next, you can see there is the other type is the transient hypogammaglobulinemia of infancy. There is an abnormal delay in the initiation of IgG synthesis. And due to this deficiency of IgG synthesis, there is recurrent repeated otitis media and respiratory infections are the common diseases found in these conditions. Then, as we have discussed, that is the selective immunoglobulin deficiency, which is due to the cause of IgA deficiency, and it is a failure of heavy chain gene switching. And it is the most common, the clinical conditions or the most target organ is the respiratory infections and the gastrointestinal infections. In other cases, there may be selective IgM deficiency or deficiency of one or more IgG subclass. Patients with a deficiency of IgA should not be treated with gamma globulin because these patients may form antibodies against the foreign IgA and by cross reactions deplete their already low level of IgA. Next comes the common variable immunodeficiency. Here, in the case of common variable immunodeficiency, there is late onset of hypogammaglobulinemia, that is in the year of 15 to 35 years of age. So usually this onset in the later stages of life, not in the infant stage as we have already seen in the X-linked hypogammaglobulinemia. And here, basically, what happens that usually adults are mostly affected, and it is characterized by recurrent pyogenic infections and an increased incidence of autoimmune diseases. Malabsorption and giardiasis are common type of diseases, and the total level of immunoglobulin level is usually less than 300 mg per 100 ml with IgG less than 250 mg per ml. Now here what happens that these cells may be present in circulation in normal numbers, but they appear defective in their inability to differentiate into plasma cells and secrete immunoglobulins. Next important condition is the immunodeficiency with hyper IgM. Now here it is also an X-linked, some are X-linked and some are autosomal recessive diseases. In autosomal recessive diseases means that which are not sex chromosomes, they may cause, or in some cases the X chromosome is mutation or some changes in the X chromosomes are also responsible for due to conditions called as immunodeficiency with hyper IgM. Now here what happens that it is low IgA and IgG levels are seen with elevated IgM. As the name suggests, there is a high level of IgM, but IgA and IgG antibodies are decreased, and the IgM molecules appear to be normal structure and possess antibody activity. Patient shows enhanced susceptibility to infections and autoimmune processes such as thrombocytopenia, neutropenia, hemolytic anemia, and renal lesions. Some patients develop malignant infiltration with IgM producing cells. Elevated IgM level with immunodeficiency sometimes are also seen in congenital rubella. The next important B cell deficiency is of transcobalamin 2 deficiency. It is an autosomal recessive disease, and it causes there is a slow metabolic effects of vitamin B12 deficiency. And we know that three important factors which are responsible for red blood synthesis are iron, then folic acid, and vitamin B12. Whereas iron causes microcytic anemia, whereas vitamin B12 and folic acid deficiency causes macrocytic anemia, and that is also called as the
megaloblastic anemia. That means that red blood cells are enlarged in such cases, and there is also intestinal villus atrophy. So the associated immunoglobulin defects are depleted plasma cells, then diminished immunoglobulin levels, and impaired phagocytosis. Treatment is that with vitamin B12 has been reported to restore hematopoietic, gastrointestinal, and B cell functions, but not phagocytic activity. So these are some of the important B cell deficiencies. If again we can summarize this, so first is the Bruton's disease, which is also called as the X-linked A-gamma globulinemia. Then transient hypogamma globulinemia of infancy. Then comes the common variable immunodeficiency, then selective immunoglobulin deficiency, immunodeficiency with hyper IgM, and transcobalamin 2 deficiencies. Now next we will discuss about other specific immunodeficiency caused by the T cells. So T cell deficiency, the first important is the thymic aplasia, that is also called as the D. Georgi syndrome. Then T cells are deficient or absent in the circulation, and this is because of the defect in the during the embryological development, and a defect affecting the third and fourth for pharyngeal pouches, which leads to aplasia or hypoplasia of the thymus and parathyroid gland. So during the embryonic life, there is, or when the fetus is developing, so at that time there is a development defect in the third and fourth pharyngeal pouches, which are responsible for to formation of thymus and parathyroid glands. And we know that these glands are important, or they are responsible for the differentiation of immune cells into T cells. So as because there is not proper development of thymus and parathyroid glands, so T cells, so the immune cells which are formed are not able to differentiate themselves into T cells, and there is a deficiency of T cells, and therefore it is also called as the thymic aplasia. Now here another important thing is that the immunodeficiency primarily involves cell-mediated immunity. The thymus-dependent areas of lymph nodes and spleen are depleted of lymphocytes. Circulating T cells are reduced in number. Delayed hypersensitivity and graft rejection are depressed. The humoral immune response mechanism is largely unaffected. So B cells functions are normal here. So majorly the affected are the cell mediated immunity, which is regulated by the T cells. So here B cells do not have any effect on their numbers or functions, but the largely affected cells are the T cells. And here there is it does not appear to be hereditary and does not show a familial incidence. It is probably due to some intrauterine infections or other complications. It is usually associated with Fallot's tetralogy and other anomalies of the heart and great vessels and a characteristic facial appearance. So these are some of the important clinical features which appear in the case of thymic aplasia. Now treatment is that it is transplantation of fetal thymus tissues. Next is important T cell deficiencies of the chronic mucocutaneous candidiasis, which is commonly seen in the children. And here this constitutes an abnormal immunological response to Candida albicans, which is an yeast cell. And here the cells, immune cells, are unable to fight or offer resistance against the Candida albicans cells, and it is mainly seen in the children's. Now here patients develop severe chronic candidiasis of the mucosa, skin and nails. They do not show increased susceptibility to other infections but often have endocrinopathies. Cell-mediated immunity to candida is deficient. In same cases, there is a total failure of T cells X response to any test antigen. Delayed hypersensitivity to candida antigens is absent, but circulating antibodies to them are found in high titers. So DTH is absent for candida albicans, but antibodies levels are high against the infection of candida. So basic defect is that children have T cell deficiency, especially for Candida albicans. Other T cells and B cells functions are normal. And clinical features, skin and mucous membranes of children infected with Candida albicans. Treatment consists primarily of antifungal drugs. Next important condition is the hyper IgM syndrome. Here patients have a high concentration of IgM, but very little IgG and IgE, they have normal T cells and B cells. This is the basically of B cell deficiency, not of T cells. Here the basic defect is of mutations in gene encoding the CD40 ligand and in the CD4 positive helper T cells, which cannot interact with the CD40 on B cells. Next, T cell. So this is hyper IgM syndrome is related to the B cell deficiency and not T cells. Next important deficiency of T cell is the purine nucleoside phosphorylase or PNP deficiency. And in that case here, the purine nucleotide phosphorylase is involved in the sequential degradation of purine to hypoxanthine and from hypoxanthine finally to uric acid. So enzyme purine nucleoside phosphorylase is involved in the sequential degradation of purines to hypoxanthine and finally to uric acid, and it is due to genetical disease, due to autosomal recessive trait which show decreased cell-mediated immunity and recurrent or chronic infections. Here we see there is an autosomal recessive inheritance trait show decreased cell-mediated immunity and recurrent or chronic infection. They usually present with hypoplastic anemia and recurrent pneumonia. Then diarrhea and candidiasis are some of the other conditions. A low serum uric acid may point to the diagnosis. So important is that to diagnose there is a low serum uric acid level. Next important is if there is a combination of both B and T cells deficiency. Till now we have seen. So here if we discuss about the T cell deficiency, so three important type. One is the thymic aplasia, which is also called as the Chediak-Higashi syndrome. Then next is the conditions called as the chronic mucocutaneous candidiasis, and third is the PNP deficiency, that is purine nucleotide phosphorylase enzyme deficiency. Now coming to the combined B and T cell, both B and T cells are deficient. So first here in combined B cell and T cell deficiency, so first important is here is the cellular immunodeficiency with abnormal immunoglobulins, or first is the severe combined immunodeficiency, that is SCID, and they are inherited in the autosomal recessive mode, and X-linked SCID have a defect in IL-2 receptor on T cell, and autosomal SCID mutation in the gene encoding a tyrosine kinase, that is a ZAP70 gene, that play a role in signal transduction of T cells. So here both here you can see that T cells and B cells are both equally affected. Here adenosine deaminase and purine nucleoside phosphorylase deficiency is there, and we already know that it is an important part of purine metabolic pathway. Purine nucleoside phosphorylase is an essential enzyme for metabolism of cytosine and inosine to purines. Absence of enzymes causes accumulation of DATP, an inhibitor of ribonucleotide reductase. Decrease in the precursors of DNA causes lymphopenia, neutropenia, and thrombocytopenia. Clinical features are recurrent infections caused by bacteria, viruses, and fungi. Pneumocystis pneumonia is the most common in infants. Treatment is the bone marrow transplants, injection of ADA conjugated to polyethylene glycol, and gene therapy. Next comes the cellular immunodeficiency with abnormal immunoglobulin synthesis, which is also called as the Naselov syndrome. Here, there is a depressed cell-mediated immunity associated with selectively elevated, decreased, or normal levels of immunoglobulin. Patients are susceptible to recurrent viral, fungal, bacterial, and protozoal infections. Here, one important thing is that usually here there is a diminished bactericidal capacity of the T cells and B cells, and these consistent features are a marked deficiency of T cell immunity or varying degree of deficiency of B cell immunity. Patients are susceptible to recurrent fungal, bacterial, viral, and protozoal diseases. Abundant plasma cells are seen in the spleen, lymph nodes, intestines, and elsewhere in the body. Thymic aplasia occurs with lymphoid depletions. Next important is the ataxia telangiectasia. What is ataxia telangiectasia? There is a hereditary conditions which is transmitted in the autosomal recessive mode where combined immunodeficiency is associated with cerebellar ataxia. Usually the brain part is affected, and chorioarthroid movements which are usually I beg your pardon, ataxia and chorioathetoid movements which are usually noticed in infancy. Telangiectasia involving the conjunctiva, face, and other parts of the body usually appears at 5 or 6 years of age. Next important is the treatment is bone marrow treatment. Here includes that these things should be supplemented through different factors, especially the transfer factors, then bone marrow transplantations, and thymus transplantations. Next is the Wiskott-Aldrich syndrome, and this is also an important type of combined immunodeficiency, and it is a X-linked disease, recessive disease characterized by thrombocytopenia, elevated Ig levels, and thymic hypoplasia. Next is the immunodeficiency with thymoma, usually in adults, consists of benign thymic tumor, impaired cell-mediated immunity, and a GABA-globulinemia. Immunodeficiency with short-limbed dwarfism. It is inherited as autosomal recessive. Clinical features are distinct form of short-limbed dwarfism, ectodermal dysplasia, thymic defects, and enhanced susceptibility to infections. Then episodic lymphopenia and lymphocytotoxin. The patients lack immunological memory, so the secondary antibody is abolished. The disease is familial. Next important is the recurrent infections with complement deficiency. Now, coming to the complement deficiency, this is the non-specific deficiency. So here you see C3 deficiency, pyogenic bacteria such as Staph aureus, C6, 7, 8, 9 deficiency, which are prone to bacteremia with Neisseria infections. Then autoimmune deficiency diseases. Patients with C2 and C4 deficiency have diseases resembling SLE, systemic lupus erythematosus, or other autoimmune diseases. Then paroxysmal nocturnal hemoglobinuria, rare disease it is, and it is decay in the gene encoding DAF, decay accelerating factor, on the surface of blood cell precursor, leading to an increased activation of complement. So these are some of the important complement deficiency. Next, other non-specific deficiency is phagocyte deficiency. So phagocytosis may be impaired either by intrinsic or extrinsic defects. Chronic granulomatous disease, X-linked disease that appears by the age of 2 years. Basic defect is the lack of NADPH oxidase. Then comes the Chediak-Higashi syndrome, which is an autosomal recessive disorder, and it is caused by the mutation in the LYST gene in the neutrophil, which is also called as the lysosomal trafficking gene. And as such, the lysosomes are not able to act on the engulfed bacteria, and thus bacteria are able to serve. So phagocytic activity is hindered or affected, and entire phagocytic functions are not able to destroy the bacteria. Next is the Job syndrome. So main defect is failure to produce gamma interferons by helper T cells. The enzyme deficiency is usually myeloperoxidase deficiency, which are secreted by like neutrophils, peroxidase, which helps in eliminating the bacteria or other pathogens through phagocytic activity. Then leukocyte G6PD deficiency. Then comes the lazy leukocyte syndrome, patients with defective neutrophil chemotaxis. Then acquired immunodeficiency, which is the secondary immunodeficiency. Till now, we have discussed about the primary immunodeficiency. So some of the important common causes of secondary immunodeficiency is that the immune response, in which immune responsiveness are depressed, non-specifically by many factors such as malnutrition, infections, malignancies, therapeutic agents, excessive loss of serum proteins. It can be discussed under following, that is the B cell deficiency, common variable A gamma globulinemia. The number of B cells is usually normal, but the ability to synthesize IgG is reduced. The T cell deficiency, that is usually due to acquired immunodeficiency syndrome and measles virus infection. Then third is the complement deficiency. It is basically due to liver failure, which reduces the synthesis of complement proteins, and malnutrition, reduced supply of amino acids, and thereby reduce the synthesis of complement proteins. Next is the phagocyte deficiency, neutropenia, neutrophil count below 500 per microliter. Common causes of neutropenia include cytotoxic drugs, leukemia, and autoimmune diseases. Laboratory evaluation of immune competence. So how we can evaluate it, that the level of immunocompetence of an individual, and it is obviously through the laboratory diagnosis. So we will discuss some of the important aspects of laboratory aspects in diagnosing the immunodeficiency diseases. So the integrity of human immune system depends on the presence of adequate number of functionally competent cells. And the several cardinal clinical manifestations of failure in immune competence include increased frequency of infections, failure to clear infections rapidly despite adequate therapy, dissemination of local infections, and occurrence of opportunistic infections. So these are some of the important clinical manifestations in the case of immunodeficiency disease. So what are the tests which helps to detect the immunocompetence ability of the cells? So first is the non-specific testing like CBC, complete blood count and differential counting, then quantitating the serum immunoglobulin levels. Specific testing is the analysis of T cells and their subsets, evaluation of T cell functions, enumeration of T cell subsets. Then delayed hypersensitivity skin test. Skin testing is useful only in children who are old enough to have received vaccines or who have been exposed to a number of natural antigens. Some of the example of delayed hypersensitivity skin test is tuberculin skin test and contact sensitivity. Then lymphocyte proliferation test. The functional activity of T cells can be assessed in vitro by their ability to proliferate and transform into blast cells in the presence of nitrogen antigens in normal persons. Stimulating indices of 10 to 100 are observed with phytohemagglutinin. In enumeration of T cell subsets, immunofluorescence and fluorescent activated cell sorter. So here you can see some of the major tests for B cell immunocompetence. Total B cells by flow cytometry with monoclonal antibodies to CD19 or CD20 or antibodies to H or L chains. Then immunoglobulin concentration, IgG, IgA or IgM through radial immunodiffusion or rate nephrometry with specific anti-H or anti-L chains, anti-sera, antibody to specific epitopes or microorganisms through ELISA, RIA, ignition, precipitation, and other immunological reactions. Then screening for complement deficiency for components for C3 to C9, determination of hemolytic complement activity CH50, generally adequately screen for congenital lack of one of these components. In genetic defect of complement, that is C6 deficiency, the entire activity of the protein is lost and hence the lactic function of the entire sequence is blocked. Thus, CH50 values approach zero in acquired deficiency. Identification of specific component defects. Generally, specific anticida are used in the clinical laboratory in either radial immunodeficient diffusion or nephrometric test, phagocytic cells through enumeration of polymorphonuclear cells and enumeration of monocyte macrophages. And some of the important functional assays are nitroclue tetrazolium dye reduction, chemiluminescence, dichlorofluorescence by flow cytometry, and enumeration of natural killer cells through monoclonal antibodies to specific cell surface. CD antigens to NK cells include CD56 and CD16. So these are some of the important laboratory tests, specific, non-specific tests, as well as functional tests, which can indicate or which can show the functional competence, immunocompetence of the cells, and it will help in the diagnosis of different type of immunodeficiency. So with this, I conclude by today's lecture. I hope it would have been beneficial, and it would have helped you to gain your knowledge in this chapter. If you like my lecture, please do like and subscribe my channel so that I remain motivated to bring some more topics for you. So with this, I to conclude today's lecture. Thank you all for your patience learning.